Question 1. A 60-year-old male collapses. A bystander initiates CPR. Upon arrival, you find the patient is unresponsive, pulseless, and on the monitor, a chaotic, disorganized rhythm is seen. What is the first priority action after confirming pulselessness? A. Administer 1 mg of epinephrine 4. B. Establish an advanced airway. C. Defibrillate immediately. D. Continue chest compressions while preparing for defibrillation. Answer: D. Continue chest compressions while preparing for defibrillation. This question tests the immediate actions for a pulseless patient in cardiac arrest, specifically when a shockable rhythm like ventricular fibrillation, VF, is present. The key phrase, chaotic, disorganized rhythm, indicates VF. While defibrillation is the definitive treatment for VF, high-quality chest compressions must continue with minimal interruptions until the defibrillator is charged and ready to deliver the shock. Giving medications or establishing an advanced airway comes after initial compressions and the first shock attempt. Remember, good compressions buy time and improve the chances of a successful shock, so always prioritize minimizing hands-off time. Question 2. During adult cardiac arrest, what is the recommended dose and route for the initial administration of epinephrine? A. 0.5 mg 4 push every 3 to 5 minutes. B. 1 mg 4 push every 3 to 5 minutes. C. 2 mg 4 push once after every 2 minutes of CPR. D. 10 mg 4 push as a one-time dose. Answer: B. 1 mg 4 push every 3 to 5 minutes. This question focuses on the correct dosage and timing of epinephrine in adult cardiac arrest, a critical medication in the ACLS algorithm. The standard dose of epinephrine for adult cardiac arrest is 1 mg administered intravenously, 4, or intraosseously, IO, repeated every 3 to 5 minutes for the duration of the resuscitation attempt. Giving the wrong dose or timing can be detrimental to patient outcomes. Always stick to the guideline recommended dose to maximize effectiveness. Question 3. A patient presents with symptomatic bradycardia, heart rate 40 bpm, with hypotension and altered mental status. After ensuring airway, breathing, and circulation, what is the initial pharmacologic intervention according to the bradycardia algorithm? A. Dopamine infusion. B. Epinephrine infusion. C. Atropine 0.5 mg 4. D. Transcutaneous pacing. Answer: C. Atropine 0.5 mg 4. This question tests the initial pharmacologic management of symptomatic bradycardia. The keywords symptomatic bradycardia, hypotension, and altered mental status indicate the need for immediate intervention. According to the ACLS bradycardia algorithm, atropine is the first-line drug for symptomatic bradycardia, administered as a 0.5 mg 4 push, repeated every 3 to 5 minutes up to a total dose of 3 mg. While pacing and other infusions might be necessary if atropine is ineffective, atropine is the initial drug of choice to try and increase the heart rate. Question 4. What end-tidal CO2, EtCO2, value during CPR indicates high-quality chest compressions and adequate coronary perfusion? A. Less than 10 mm of mercury. B. 10 to 20 mm of mercury. C. Greater than 20 mm of mercury. D. No specific value indicates quality compressions. Answer: C. Greater than 20 mm of mercury. This question assesses understanding of capnography as a real-time monitor for CPR quality. End-tidal CO2, EtCO2, Measures the CO2 exhaled at the end of a breath and is a good indicator of cardiac output and pulmonary blood flow during CPR. An EtCO2 consistently less than 10 millimeters of mercury suggests inadequate chest compressions, while a value consistently greater than 20 millimeters of mercury is a strong indicator of high-quality chest compressions and better chances of achieving return of spontaneous circulation, ROSC. Monitoring EtCO2 is a crucial way to know if your compressions are effective. Question 5. You are managing a patient in ventricular fibrillation, VF, cardiac arrest. After the second defibrillation, the patient remains in VF. What is the next recommended drug administration? A. Atropine 1 mg 4. B. Amiodarone 300 mg 4 push. C. Lidocaine 1.5 mg per kilogram 4. D. Epinephrine 1 mg 4. Answer: D. Epinephrine 1 mg 4. This question tests the sequence of interventions in the adult cardiac arrest algorithm, specifically for shockable rhythms. The keyword second defibrillation is important, as it places the timing of medication. After the initial defibrillation and subsequent CPR, if VF persists, epinephrine 1 mg 4 is given. Amiodarone or lidocaine are considered antiarrhythmics that typically come after the second shock, but epinephrine is administered after the second shock, before the third shock, and before the antiarrhythmics in the VF/pulseless VT algorithm. Question 6. A 45-year-old patient presents with narrow complex tachycardia at a rate of 180 bpm. The patient is stable, with no signs of shock, altered mental status, acute heart failure, or ischemic chest discomfort. What is the first intervention you should attempt? A. Synchronized cardioversion. B. Adenosine 6 mg 4 rapid push. C. Amiodarone 150 mg 4 over 10 minutes. D. Vagal maneuvers. Answer: D. Vagal maneuvers. This question assesses the initial management of stable narrow complex tachycardia. The key information is stable and narrow complex tachycardia. For stable patients with narrow complex tachycardia, the very first step is to attempt vagal maneuvers, like Valsalva maneuver or carotid sinus massage, if no contraindications. These non-pharmacologic interventions can often terminate supraventricular tachycardias before medication is needed. If vagal maneuvers are unsuccessful, then adenosine would be the next step. Question 7. What is the maximum recommended total dose of atropine that can be given for symptomatic bradycardia? A. 1 mg. B. 2 mg. C. 3 mg. D. 0.5 mg. Answer: C. 3 mg. This question specifically tests the total dose limit for atropine in the bradycardia algorithm. While the initial dose is 0.5 mg 4, it can be repeated every 3 to 5 minutes. The maximum total recommended dose for atropine for symptomatic bradycardia is 3 mg. Exceeding this dose is unlikely to provide further benefit and may increase side effects. It's crucial to know the upper limits of medications in ACLS. Question 8. A patient has achieved return of spontaneous circulation, ROSC, after cardiac arrest. What is the target systolic blood pressure for post-cardiac arrest care? A. Below 90 millimeters of mercury. B. 90 to 100 millimeters of mercury. C. Greater than or equal to 90 millimeters of mercury but less than 180 millimeters of mercury. D. 100 to 120 millimeters of mercury. Answer: C. Greater than or equal to 90 millimeters of mercury but less than 180 millimeters of mercury. This question addresses the critical hemodynamic management post-ROSC. The goal is to optimize cerebral and myocardial perfusion while avoiding hypotension or excessive hypertension. Current guidelines recommend maintaining a systolic blood pressure, SBP, of at least 90 mm of mercury and a mean arterial pressure, MAP, of at least 65 mm of mercury to ensure adequate organ perfusion. However, excessively high blood pressure should also be avoided. The target is to find a balance, generally maintaining SBP at or above 90 mm of mercury. Question 9. In the adult cardiac arrest algorithm, what is the role of an advanced airway, e.g., endotracheal tube, during continuous chest compressions? A. It replaces the need for chest compressions. B. It allows for continuous chest compressions with asynchronous ventilations. C. It is the first priority intervention upon arrival at a cardiac arrest. D. It should only be placed after ROSC is achieved. Answer: B. It allows for continuous chest compressions with asynchronous ventilations. This question clarifies the benefit of an advanced airway in cardiac arrest. An advanced airway, like an endotracheal tube or laryngeal mask airway, allows rescuers to provide ventilations without interrupting chest compressions. This means you can deliver one breath every 6 seconds, or 10 breaths per minute, while compressions continue uninterrupted, which is crucial for maintaining coronary and cerebral perfusion. Advanced airways are not the first priority and do not replace compressions, rather, they enhance the efficiency of resuscitation. Question 10. You are managing a patient with pulseless electrical activity, PEA. After starting CPR, what is the most important next step? A. Administer atropine 1 mg 4. B. Prepare for immediate defibrillation. C. Identify and treat reversible causes. D. Insert an advanced airway. Answer: C. Identify and treat reversible causes. This question highlights the critical management strategy for pulseless electrical activity, PEA. Unlike shockable rhythms, PEA does not respond to defibrillation. The most crucial action for PEA is to search for and treat the underlying reversible causes, often referred to as the H's and T's: hypovolemia, hypoxia, hydrogen ion, acidosis, hypo/hyperkalemia, hypothermia, toxins, tamponade, tension pneumothorax, thrombosis pulmonary, thrombosis coronary. While CPR and epinephrine are administered, identifying and treating these causes is paramount for potential ROSC. Question 11. What is the recommended energy dose for the initial defibrillation of an adult with ventricular fibrillation, VF, using a biphasic defibrillator? A. 120 J. B. 200 J. C. 360 J. D. Manufacturer-specific dose, typically 120 to 200 J. Answer: D. Manufacturer-specific dose, typically 120 to 200 J. This question tests knowledge of biphasic defibrillation energy settings. Unlike monophasic defibrillators, which always use 360 J, biphasic defibrillators have varying energy settings depending on the specific device. The general recommendation for initial biphasic defibrillation of VF is the manufacturer's recommended maximal dose, which is typically in the range of 120 to 200 joules. If the manufacturer's dose is unknown, a dose of 200 J can be used. Always know your equipment and its recommended settings. Question 12. A patient with a heart rate of 160 BPM, regular, narrow complex rhythm, presents with chest pain and mild shortness of breath. The patient is hypotensive, BP 80/50 mmHg. What is the most appropriate next intervention? A. Vagal maneuvers. B. Adenosine 6 mg for rapid push. C. Synchronized cardioversion. D. Amiodarone 150 mg for over 10 minutes. Answer: C. Synchronized cardioversion. This question assesses the management of unstable tachycardia. The keywords hypotensive, chest pain, and shortness of breath indicate the patient is unstable, even with a narrow complex rhythm. For any unstable tachycardia, regardless of whether it's narrow or wide complex, the immediate intervention is synchronized cardioversion. Pharmacologic agents like adenosine or amiodarone are reserved for stable tachycardias, and vagal maneuvers are for stable narrow complex rhythms. When in doubt and unstable, shock is the answer. Question 13. Which of the following is an absolute contraindication to the administration of nitroglycerin in a patient with suspected acute coronary syndrome, ACS? A. Mild headache. B. Systolic blood pressure of 110 mm of mercury. C. Recent use of a phosphodiesterase inhibitor, e.g., sildenafil, within 24 to 48 hours. D. Chronic stable angina. Answer: C. Recent use of a phosphodiesterase inhibitor, e.g., sildenafil, within 24 to 48 hours. This question tests a critical contraindication for nitroglycerin. While nitroglycerin is a staple in ACS management, it is absolutely contraindicated if the patient has recently taken phosphodiesterase inhibitors, like sildenafil, tadalafil, or vardenafil, within 24 to 48 hours. The combination can lead to a severe and life-threatening drop in blood pressure. Mild headache is a common side effect, and chronic angina is an indication, not a contraindication. Always ask about recent medication use, especially for erectile dysfunction drugs, before giving nitroglycerin. Question 14. What is the appropriate depth for chest compressions in an adult during CPR? A. At least 1 inch 2.5 centimeters. B. At least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters. C. At least 2.4 inches 6 centimeters. D. No specific depth, just hard and fast. Answer: B. At least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters. This question focuses on the specific parameters for high-quality chest compressions in adults. The guidelines specify a compression depth of at least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters. This depth ensures adequate blood flow without causing excessive injury. Hard and fast is a general reminder, but specific depth and rate, 100 to 120 compressions/minute, are crucial for effective CPR. Question 15. A patient experiences sudden cardiac arrest. The ECG monitor shows asystole. After initiating CPR and administering the first dose of epinephrine, what is the next most critical action? A. Defibrillate immediately. B. Continue CPR and consider reversible causes. C. Administer atropine 1 mg for. D. Insert an advanced airway. Answer: B. Continue CPR and consider reversible causes. This question addresses the management of asystole, a non-shockable rhythm. For asystole, defibrillation is ineffective, and atropine is no longer recommended. After confirming asystole, starting high-quality CPR and administering epinephrine are the initial steps. The most important ongoing action is to continue CPR while diligently searching for and treating any reversible causes, the H's and T's, as these are the only pathways to potential ROSC in asystole. Question 16. What is the recommended initial dose of adenosine for stable narrow complex tachycardia? A. 3 mg for rapid push. B. 6 mg for rapid push. C. 12 mg for rapid push. D. 1 mg per kilogram for rapid push. Answer: B. 6 mg for rapid push. This question tests the initial dose of adenosine, a key drug for stable narrow complex tachycardias. The first dose of adenosine is 6 mg administered as a rapid 4 push, followed immediately by a flush of 20 ml of saline. This rapid administration is crucial because adenosine has a very short half-life, less than 10 seconds. If the first dose is ineffective, a second dose of 12 mg may be given. Question 17. A patient in cardiac arrest has a profound hypothermic core temperature of 28 degrees Celsius (82.4 degrees Fahrenheit). How does severe hypothermia affect the cardiac arrest algorithm, specifically regarding drug administration? A. All medications should be withheld until the patient is warmed. B. Medications should be given at double the standard dose. C. Medications should be given at standard doses, but only after core temperature is above 30 degrees Celsius. D. Medications should be given at standard doses, but effects may be unpredictable. Answer: C. Medications should be given at standard doses, but only after core temperature is above 30 degrees Celsius. This question addresses a critical consideration in cardiac arrest with severe hypothermia. Below 30 degrees Celsius (86 degrees Fahrenheit), cardiac medications may be ineffective or even toxic due to altered metabolism. Therefore, in severe hypothermia, core temp less than 30 degrees Celsius, drug administration should be spaced out or withheld until the core temperature rises above 30 degrees Celsius (86 degrees Fahrenheit). Once the temperature is above 30 degrees Celsius, standard doses of medications can be given, typically at extended intervals. Always prioritize rewarming the hypothermic patient. Question 18. After achieving ROSC, a patient remains comatose. Which intervention is a critical component of post-cardiac arrest care for this patient? A. Immediate reinduction of hypothermia to 32 to 36 degrees Celsius, targeted temperature management. B. Administering a bolus of 500 milliliters of normal saline every hour. C. Maintaining a core body temperature of 38 degrees Celsius (100.4 degrees Fahrenheit). D. Providing immediate high-flow oxygen at 15 liters per minute via non-rebreather mask indefinitely. Answer: A. Immediate reinduction of hypothermia to 32 to 36 degrees Celsius, targeted temperature management. This question highlights a crucial aspect of post-cardiac arrest care for unresponsive patients. For comatose patients, i.e., those who do not follow commands, after ROSC, targeted temperature management, TTM, is recommended, typically maintaining a core body temperature between 32 degrees Celsius and 36 degrees Celsius for at least 24 hours. TTM has been shown to improve neurologic outcomes. Maintaining normothermia or intentionally causing hyperthermia is not recommended, and oxygen should be titrated to avoid hyperoxia. Question 19. What is the primary purpose of defibrillation in ventricular fibrillation, VF? A. To convert the rhythm to asystole, allowing the heart to rest. B. To directly stimulate organized electrical activity in the heart. C. To depolarize a critical mass of myocardial cells simultaneously to terminate the chaotic rhythm. D. To electrically pace the heart. Answer: C. To depolarize a critical mass of myocardial cells simultaneously to terminate the chaotic rhythm. This question asks about the fundamental mechanism of defibrillation. The primary goal of defibrillation is not to restart the heart directly or pace it, but rather to momentarily stop all electrical activity in the heart. This allows the heart's natural pacemaker, the SA node, to hopefully resume organized electrical activity, thereby terminating the chaotic ventricular fibrillation. Think of it as hitting a reset button on the heart's electrical system. Question 20. During resuscitation of a patient in cardiac arrest, you notice a sudden, sustained increase in end-tidal CO2, EtCO2, from 15 millimeters of mercury to 45 millimeters of mercury. What does this likely indicate? A. Worsening of the patient's condition. B. Dislodgement of the endotracheal tube. C. Return of spontaneous circulation, ROSC. D. Improvement in ventilation but not perfusion. Answer: C. Return of spontaneous circulation, ROSC. This question tests the interpretation of a key capnography finding during cardiac arrest. A sudden and sustained increase in EtCO2, typically to values greater than 35 to 40 millimeters of mercury, is a strong indicator of return of spontaneous circulation, ROSC. This rise reflects a sudden increase in pulmonary blood flow as the heart resumes pumping effectively. This is a crucial sign to watch for during resuscitation. Question 21. What is the recommended management for a patient presenting with symptomatic monomorphic wide complex tachycardia, heart rate 160 bpm, who is hypotensive, BP 70/40 millimeter of mercury, and unresponsive? A. Adenosine 6 mg for rapid push. B. Amiodarone 150 mg for over 10 minutes. C. Synchronized cardioversion. D. Procainamide infusion. Answer: C. Synchronized cardioversion. This question presents a clear case of unstable wide complex tachycardia. The keywords symptomatic, hypotensive, and unresponsive are critical, indicating instability. Regardless of the rhythm being monomorphic or polymorphic, any wide complex tachycardia with signs of instability, e.g., hypotension, altered mental status, acute heart failure, ischemic chest pain, requires immediate synchronized cardioversion. Always remember that instability trumps rhythm morphology in determining immediate management. Question 22. A patient with acute coronary syndrome, ACS, develops pulmonary edema and crackles upon auscultation. What is the most appropriate initial management for this patient? A. Aggressive intravenous fluid bolus. B. Administer nitroglycerin and consider positive pressure ventilation if needed. C. Administer atropine 0.5 mg for. D. Prepare for immediate cardioversion. Answer: B. Administer nitroglycerin and consider positive pressure ventilation if needed. This question addresses the management of acute heart failure with pulmonary edema in the context of ACS. The keywords pulmonary edema and crackles indicate fluid overload in the lungs. Nitroglycerin, a vasodilator, helps reduce preload and afterload, thereby decreasing fluid in the lungs and improving cardiac function. If breathing is severely compromised, positive pressure ventilation, e.g., CPAP or BiPAP, can help improve oxygenation and reduce the work of breathing. Aggressive fluids would worsen the pulmonary edema, and atropine or cardioversion are not indicated for pulmonary edema itself. Question 23. What is the recommended post-cardiac arrest oxygen saturation, SpO2, target range? A. 90 to 94%. B. 94 to 98%. C. 98 to 100%. D. Maintain maximum oxygen delivery, 100% FiO2, indefinitely. Answer: B. 94 to 98%. This question tests the appropriate oxygenation target in post-cardiac arrest care. While hypoxia, low oxygen, is detrimental, hyperoxia, excessively high oxygen, can also be harmful, potentially leading to oxidative stress and worsen neurological outcomes. Current guidelines recommend titrating oxygen to maintain an SpO2 between 94% and 98% in patients who have achieved ROSC. Avoid routine hyperoxia, as it offers no benefit and may be harmful. Question 24. What is the primary indication for transcutaneous pacing, TCP, in the bradycardia algorithm? A. Asystole. B. Symptomatic bradycardia unresponsive to atropine. C. Any bradycardia with a heart rate below 50 bpm. D. Bradycardia with ST segment elevation. Answer: B. Symptomatic bradycardia unresponsive to atropine. This question focuses on the appropriate use of transcutaneous pacing, TCP. TCP is indicated for symptomatic bradycardia when atropine has been ineffective or is unlikely to be effective, e.g., high-degree AV block. It provides an electrical impulse to temporarily pace the heart until a more definitive solution, like a permanent pacemaker, can be implemented. TCP is not used for asystole, as the heart has no electrical activity to capture, and is not solely based on heart rate but rather the presence of symptoms. Question 25. A 70-year-old patient presents with new-onset, sudden, focal neurological deficits. The patient denies trauma. What is the most important initial diagnostic study to perform? A. Complete blood count, CBC. B. Electrocardiogram, ECG. C. Non-contrast head CT scan. D. Chest X-ray. Answer: C. Non-contrast head CT scan. This question addresses the critical initial evaluation for a suspected stroke. The keywords new-onset, sudden, focal neurological deficits strongly suggest a stroke. The most important initial diagnostic test is a non-contrast head CT scan, which is crucial to rapidly differentiate between an ischemic stroke, clot, and a hemorrhagic stroke, bleed. This distinction is vital because thrombolytic therapy, clot-busting drugs, is contraindicated in hemorrhagic stroke. Question 26. What is the appropriate initial energy dose for synchronized cardioversion of unstable monomorphic ventricular tachycardia? A. 50 J. B. 100 J. C. 200 J. D. 360 J. Answer: B. 100 J. This question specifies the initial energy dose for unstable monomorphic ventricular tachycardia, VT, requiring synchronized cardioversion. For monomorphic VT, the recommended initial synchronized cardioversion energy is 100 joules, biphasic. If this is unsuccessful, subsequent shocks should be delivered with escalating energy. Knowing the specific energy levels for different unstable rhythms is important for effective cardioversion. Question 27. What is the recommended fluid bolus amount for initial management of hypovolemic shock in an adult? A. 100 milliliters. B. 250 milliliters. C. 500 milliliters to 1 liter. D. 2 to 3 liters. Answer: C. 500 milliliters to 1 liter. This question addresses the initial fluid management in hypovolemic shock. For adults with hypovolemic shock, the recommended initial fluid bolus is 500 milliliters to 1 liter of isotonic crystalloid, e.g., normal saline or lactated ringers, administered rapidly. The patient's response to this initial bolus should then guide further fluid administration. Large, rapid boluses, e.g., 2 to 3 liters, are often reserved for severe cases or trauma and may be too aggressive initially for all forms of hypovolemic shock. Question 28. A patient is in cardiac arrest due to suspected opioid overdose, confirmed by pinpoint pupils and respiratory depression prior to arrest. What is the appropriate management in addition to high-quality CPR and standard ACLS interventions? A. Immediate administration of flumazenol. B. Administration of naloxone. C. High-dose dopamine infusion. D. Continue CPR for 30 minutes before considering other interventions. Answer: B. Administration of naloxone. This question tests the management of cardiac arrest in a specific special circumstance, opioid overdose. The keywords opioid overdose, pinpoint pupils, and respiratory depression point directly to this cause. In suspected opioid overdose, naloxone should be administered in addition to standard ACLS care. While CPR and epinephrine are essential, addressing the underlying opioid effect with naloxone is critical for potential reversal. Flumazenol is for benzodiazepine overdose, not opioids. Question 29. What is the primary goal of therapeutic hypothermia, targeted temperature management, in post-cardiac arrest care for comatose patients? A. To prevent aspiration pneumonia. B. To reduce metabolic rate and improve neurological outcome. C. To lower core body temperature to prevent shivering. D. To improve cardiac output and blood pressure. Answer: B. To reduce metabolic rate and improve neurological outcome. This question asks about the primary benefit of targeted temperature management, TTM, following cardiac arrest. TTM, where the body is cooled to 32 to 36 degrees Celsius, is primarily aimed at reducing the brain's metabolic rate and mitigating secondary brain injury that occurs after reperfusion. This reduction in metabolic demand helps protect neurological function and improves the chances of a good neurological outcome for comatose patients who have achieved ROSC. Question 30. You are managing a patient with pulseless ventricular tachycardia, private. After the first defibrillation, the patient remains in private. What is the next step? A. Administer atropine 1 mg 4. B. Continue CPR and administer epinephrine 1 mg 4. C. Perform synchronized cardioversion. D. Administer amiodarone 300 mg 4. Answer: B. Continue CPR and administer epinephrine 1 mg 4. This question specifically addresses the sequence of interventions for pulseless ventricular tachycardia, private, in cardiac arrest, which is treated identically to VF. After the first defibrillation attempt, if the rhythm remains private/VF, immediate resumption of high-quality CPR for 2 minutes is crucial, followed by the administration of epinephrine 1 mg 4. Antiarrhythmics like amiodarone come after the second shock, but epinephrine is critical at this stage. Question 31. What is the primary difference between synchronized cardioversion and defibrillation? A. Synchronized cardioversion uses a higher energy dose. B. Defibrillation is used for stable rhythms, while synchronized cardioversion is for unstable rhythms. C. Synchronized cardioversion delivers a shock timed with the R wave, whereas defibrillation is unsynchronized. D. Synchronized cardioversion does not require sedation, while defibrillation does. Answer: C. Synchronized cardioversion delivers a shock timed with the R wave, whereas defibrillation is unsynchronized. This question clarifies a fundamental distinction between two electrical therapies. The key difference is timing. Synchronized cardioversion delivers a shock precisely timed with the R wave, the peak of ventricular depolarization, to avoid inducing ventricular fibrillation. Defibrillation, on the other hand, delivers an immediate, unsynchronized shock, typically for pulseless rhythms like VF or pulseless VT where there is no organized R wave to synchronize with. This timing mechanism is critical to the safety and effectiveness of synchronized cardioversion. Question 32. In the context of the ACLS acute coronary syndrome, ACS, algorithm, what does the O in the mnemonic MONA stand for, and when is it indicated? A. Oxygen, for all patients with chest pain. B. Opioids, for severe pain relief. C. Oxygen, if SpO2 is less than 90% or signs of hypoxemia are present. D. Oxygen, only if the patient is intubated. Answer: C. Oxygen, if SpO2 is less than 90% or signs of hypoxemia are present. This question addresses the appropriate use of oxygen in ACS. While traditionally, oxygen was given to all ACS patients, current guidelines recommend oxygen only if the patient is hypoxemic, SpO2 less than 90%, or has signs of hypoxemia, respiratory distress, or heart failure. Routine administration to normoxic patients, SpO2 greater than or equal to 90%, is not recommended, as it may cause harm, e.g., vasoconstriction. Always titrate oxygen to need. Question 33. A patient presents with acute onset chest pain and ST segment elevation on ECG. The emergency department is 15 minutes away from a percutaneous coronary intervention, PCI, capable hospital, but thrombolytics are available immediately. What is the preferred reperfusion strategy based on time parameters? A. Administer thrombolytic therapy immediately. B. Transfer to the PCI-capable hospital for immediate PCI. C. Administer aspirin and nitroglycerin only. D. Wait for 30 minutes to see if the ST elevation resolves spontaneously. Answer: B. Transfer to the PCI-capable hospital for immediate PCI. This question tests the decision-making process for reperfusion strategy in ST elevation myocardial infarction, STEMI, based on transport times. The key is the time difference. If the time from first medical contact, FMC, to balloon inflation, PCI, is expected to be less than 120 minutes, or if the FMC to PCI is less than 90 minutes, then primary PCI is the preferred reperfusion strategy over thrombolysis. Since the PCI-capable hospital is only 15 minutes away, PCI is the clear choice. Question 34. What is the recommended maximum interval for interrupting chest compressions during CPR for rhythm analysis or pulse checks? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer: B. 10 seconds. This question emphasizes the critical importance of minimizing interruptions to chest compressions during CPR. Prolonged interruptions significantly decrease coronary and cerebral perfusion, reducing the chances of successful resuscitation. Therefore, guidelines strongly recommend that any pause for rhythm analysis, pulse checks, or defibrillation should be limited to no more than 10 seconds. Always aim for continuous, high-quality compressions. Question 35. After administration of a 6 mg dose of adenosine for stable narrow complex tachycardia, the rhythm does not convert. What is the next appropriate action? A. Administer atropine 1 mg 4. B. Administer synchronized cardioversion. C. Administer a second dose of adenosine 12 mg for rapid push. D. Initiate transcutaneous pacing. Answer C. Administer a second dose of adenosine 12 mg for rapid push. This question follows up on adenosine administration for stable narrow complex tachycardia. If the initial 6 mg dose of adenosine fails to convert the rhythm, the next step is to administer a second dose of adenosine, typically 12 mg, as a rapid 4 push. Synchronized cardioversion is reserved for unstable tachycardias or if adenosine is ineffective after the second dose and the patient remains symptomatic. Question 36. You are preparing to intubate a patient in cardiac arrest. Which medication is typically used in conjunction with a sedative agent for rapid sequence intubation, RSI, if the patient is not in cardiac arrest but needs airway protection, e.g., trauma patient? A. Atropine. B. Epinephrine. C. Succinylcholine. D. Amiodarone. Answer C. Succinylcholine. This question tests knowledge of medications used for rapid sequence intubation, RSI, distinguishing it from cardiac arrest where paralysis might not be necessary. Succinylcholine is a depolarizing neuromuscular blocker commonly used for paralysis during RSI to facilitate intubation by relaxing the vocal cords and jaw. It is typically given after a sedative agent, like etomidate or ketamine, to ensure the patient is unconscious before paralysis. Atropine, epinephrine, and amiodarone are primarily cardiac medications, not sedatives or paralytics for intubation. Question 37. Which of the following is considered a non-shockable rhythm in the adult cardiac arrest algorithm? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Atrial fibrillation, AF, with rapid ventricular response. D. Asystole. Answer D. Asystole. This question asks to identify a non-shockable rhythm. In the ACLS cardiac arrest algorithm, rhythms are categorized as either shockable or non-shockable to guide treatment. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, are shockable rhythms requiring defibrillation. Asystole, which is a flatline, and pulseless electrical activity, PEA, are non-shockable rhythms, meaning defibrillation will not be effective. Atrial fibrillation is a perfusing rhythm and not part of the cardiac arrest algorithm itself. Question 38. A patient has a witnessed sudden collapse. CPR is initiated immediately. When the AED arrives, it advises NO shock advised. What is the immediate next step? A. Discontinue CPR and assess for pulse. B. Continue CPR for 2 minutes and then reassess. C. Administer epinephrine immediately. D. Prepare for immediate synchronized cardioversion. Answer B. Continue CPR for 2 minutes and then reassess. This question clarifies the action after an AED advises NO shock advised. If the AED indicates a non-shockable rhythm, like asystole or PEA, the correct immediate action is to continue high-quality CPR for 2 minutes, focusing on effective compressions and ventilations. After 2 minutes, reassess the patient's rhythm and pulse. Discontinuing CPR or administering drugs without continued compressions is incorrect, and cardioversion is not indicated for non-shockable rhythms. Question 39. What is the recommended dose and route for the initial administration of amiodarone during cardiac arrest for refractory ventricular fibrillation, VF? A. 150 mg for push. B. 300 mg for push. C. 1 mg per kilogram for push. D. 150 mg for over 10 minutes. Answer B. 300 milligrams 4 push. This question tests the initial dose of amiodarone for refractory, persistent, VF or pulseless VT in cardiac arrest. The recommended initial dose of amiodarone in this setting is a 300 milligrams 4, or IO, push. If VF/private persists after further defibrillation attempts, a second dose of 150 milligrams can be given. The 150 milligrams for over 10 minutes is for stable ventricular tachycardia, not cardiac arrest. Question 40. A patient experiences chest pain, diaphoresis, and ECG shows ST segment depression in leads V4-V6. What type of acute coronary syndrome, ACS, is most likely occurring? A. ST elevation myocardial infarction, STEMI. B. Non-ST elevation myocardial infarction, STEMI, or unstable angina. C. Prinzmetal's angina. D. Pericarditis. Answer: B. Non-ST elevation myocardial infarction, STEMI, or unstable angina. This question asks to differentiate types of ACS based on ECG findings. ST segment depression, particularly new horizontal or downsloping ST depression, combined with symptoms of ACS, strongly suggests either a non-ST elevation myocardial infarction, STEMI, or unstable angina. ST elevation is characteristic of STEMI, while Prinzmetal's angina typically presents with transient ST elevation, and pericarditis usually shows diffuse ST elevation. Question 41. When managing a patient with acute stroke symptoms, what is the crucial time limit for administering intravenous thrombolytic therapy, alteplase? A. Within 6 hours of symptom onset. B. Within 12 hours of symptom onset. C. Within 3 to 4.5 hours of symptom onset, if no contraindications. D. Thrombolytic therapy can be given at any time if the patient is stable. Answer: C. Within 3 to 4.5 hours of symptom onset, if no contraindications. This question addresses a critical time-sensitive intervention in acute ischemic stroke. For eligible patients, intravenous thrombolytic therapy with alteplase is most effective when administered within 3 hours of symptom onset, and in select cases, up to 4.5 hours. Beyond this window, the risks often outweigh the benefits. This time window is crucial for improving patient outcomes. Question 42. A 30-year-old pregnant patient in her third trimester collapses. What modification to standard CPR should be considered? A. No modifications are necessary. B. Defibrillation should be avoided. C. Manual left uterine displacement should be performed. D. Chest compressions should be shallower. Answer: C. Manual left uterine displacement should be performed. This question covers a special circumstance in cardiac arrest, pregnancy. In pregnant patients beyond 20 weeks gestation, the gravid, pregnant, uterus can compress the inferior vena cava, impairing venous return and reducing the effectiveness of chest compressions. Performing manual left uterine displacement, pushing the uterus to the left side of the patient, helps alleviate this compression, thereby improving venous return and blood flow during CPR. Defibrillation and medications are safe for the pregnant patient and fetus. Question 43. What is the initial recommended dose of aspirin for a patient presenting with suspected acute coronary syndrome, ACS? A. 81 mg chewable. B. 162 mg non-enteric coated. C. 325 mg chewable. D. 650 mg non-enteric coated. Answer: C. 325 mg chewable. This question tests the initial aspirin dose for suspected ACS. The recommended initial dose of aspirin for a patient with suspected ACS is 162 mg to 325 mg of non-enteric-coated aspirin, chewed. Chewing ensures rapid absorption and antiplatelet effect, which is critical in preventing further clot formation in a coronary artery. The 325 mg dose is commonly used for its robust initial antiplatelet effect. Question 44. What is the primary reason to administer magnesium sulfate in the setting of cardiac arrest? A. As a first-line treatment for asystole. B. For refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, in patients with suspected hypomagnesemia or polymorphic VT, torsades de pointes. C. To lower blood pressure in hypertensive emergencies. D. To convert atrial fibrillation to normal sinus rhythm. Answer: B. For refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, in patients with suspected hypomagnesemia or polymorphic VT, torsades de pointes. This question specifically asks about the indication for magnesium sulfate in cardiac arrest. Magnesium sulfate is not a general first-line drug for all cardiac arrests. Its primary indication in cardiac arrest is for refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, when torsades de pointes, a specific type of polymorphic VT associated with prolonged QT interval, is suspected, or if the patient is known to have hypomagnesemia, low magnesium levels. It helps stabilize cardiac cell membranes. Question 45. In the post-cardiac arrest phase, what is the primary goal regarding ventilation and arterial CO2 levels? A. Hyperventilation to keep PaCO2 below 30 mm of mercury. B. Hypoventilation to allow CO2 buildup for acidosis. C. Titrate ventilations to maintain PaCO2 at 40 to 45 mm of mercury, normocarbia. D. No specific target, just ensure adequate oxygenation. Answer: C. Titrate ventilations to maintain PaCO2 at 40 to 45 mm of mercury, normocarbia. This question addresses ventilation targets in post-cardiac arrest care. Both hyperventilation, leading to hypocapnia, or low CO2, and hypoventilation, leading to hypercapnia, or high CO2, can be detrimental to neurological outcomes. Therefore, the goal is to titrate ventilations to maintain normocarbia, meaning a normal arterial carbon dioxide level, PaCO2, of 40 to 45 mm of mercury. This ensures optimal cerebral blood flow and pH balance. Question 46. A patient is found unresponsive with a heart rate of 30 bpm and no pulse. The monitor shows organized electrical activity. What rhythm is this? A. Sinus bradycardia. B. Asystole. C. Pulseless electrical activity, PEA. D. Ventricular fibrillation, VF. Answer: C. Pulseless electrical activity, PEA. This question defines pulseless electrical activity, PEA. The key indicators are organized electrical activity on the monitor despite no pulse. If there's electrical activity on the ECG but no palpable pulse, it is defined as PEA. Sinus bradycardia implies a pulse, asystole is a flatline, and VF is chaotic electrical activity without organization. Recognizing PEA is crucial because it's a non-shockable rhythm that requires addressing underlying causes. Question 47. What is the primary advantage of therapeutic hypothermia, targeted temperature management, in post-cardiac arrest care? A. It significantly reduces the risk of recurrent cardiac arrest. B. It improves the likelihood of good neurological recovery in comatose patients. C. It shortens the recovery time in the hospital. D. It reduces the need for ongoing critical care medications. Answer: B. It improves the likelihood of good neurological recovery in comatose patients. This question highlights the main benefit of targeted temperature management, TTM. The primary advantage and proven benefit of TTM, maintaining a core temperature of 32 to 36 degrees Celsius, for comatose patients after cardiac arrest is to improve the likelihood of good neurological recovery. It achieves this by reducing the brain's metabolic demand and preventing secondary injury. Question 48. A patient has acute chest pain. Which of the following findings on a 12-lead ECG is most indicative of an acute ST elevation myocardial infarction, STEMI? A. T-wave inversion in lead 3. B. ST segment elevation of 1 mm in lead V1. C. ST segment elevation of 2.5 mm in leads V2 and V3 in a male patient. D. Pathologic Q waves in leads 2, 3, AVF. Answer: C. ST segment elevation of 2.5 mm in leads V2 and V3 in a male patient. This question tests specific ECG criteria for STEMI. While T-wave inversion and Q waves can indicate ischemia or prior infarction, definitive acute STEMI requires significant ST segment elevation. For males 40 years or older, new ST elevation at the J point of at least 2 mm in leads V2 and V3, or at least 1 mm in all other leads, is diagnostic of STEMI. The 2.5 mm elevation in V2-V3 specifically meets the criteria for STEMI in males. Question 49. When administering epinephrine via the intraosseous (IO) route during cardiac arrest, what is the recommended dosage compared to the intravenous 4 dose? A. Half the 4 dose. B. Double the 4 dose. C. The same dose as the 4 route. D. Epinephrine cannot be given IO. Answer: C. The same dose as the 4 route. This question addresses drug administration via the intraosseous (IO) route. The IO route is an acceptable alternative to the 4 route when 4 access cannot be rapidly established during cardiac arrest. For most ACLS medications, including epinephrine, the dosage administered via the IO route is exactly the same as the 4 dose, e.g., 1 mg of epinephrine for cardiac arrest. Remember, IO is a viable option for rapid drug delivery when 4 access is difficult. Question 50. During the resuscitation of a patient in cardiac arrest, what is the appropriate chest compression to ventilation ratio for an adult with an unsecured airway, no advanced airway? A. 15 compressions to 2 ventilations. B. 30 compressions to 2 ventilations. C. 100 compressions to 10 ventilations. D. Continuous compressions with 1 ventilation every 6 seconds. Answer: B. 30 compressions to 2 ventilations. This question tests the correct compression to ventilation ratio for an adult in cardiac arrest with an unsecured airway. For adults, when no advanced airway is in place, the recommended ratio is 30 chest compressions followed by 2 ventilations. This ratio aims to maximize chest compression fraction while still providing adequate breaths. Once an advanced airway is in place, then continuous compressions with asynchronous ventilations, 1 breath every 6 seconds, can be performed.